Thank you for allowing us to present our work today. My name is Liam Phelan, I'm a surgical registrar and I'm presenting on behalf of the Upper GI Surgery Department at the University Hospitals Birmingham NHS Foundation Trust, which is in Birmingham in the United Kingdom. We are presenting our work entitled Myotomy, a traditional gold standard treatment, individualised treatment, a contemporary gold standard, outcomes from a tertiary UK centre. We have no conflicts of interest to disclose. Achalasia is a rare disease with an incidence of 0.3 to 3 per 100,000 people. It has varying outcomes dependent on the subtype and treatment modality. The traditional gold standard treatment is Heller's myotomy, although other options include pneumatic dilatation, per-oral endoscopic myotomy or POEM, and botox injection. In some patients, it is an evolving pathology which may require multiple treatments as the disease progresses. 4 guidelines have been published on the investigation and management of achalasia in the last 2 years. However, due to its low prevalence, it is treated infrequently by all centres in the UK and care is therefore not standardised. As a result, we were interested to assess our own outcomes, comparing our gold standard of Heller's myotomy with the other treatments we offer, which are pneumatic dilatation and botox injection. Retrospective data were collected on all consecutive patients with the manometry proven achalasia. Patients were identified through a prospectively maintained database. This was supplemented with data from hospital informatics in which patients were identified using the ICD-10 code for achalasia and hospital admissions coded with cardiomyotomy plus or minus fundoplication and achalasia dilatation. Finally, to ensure a complete dataset, a departmental manometry database was searched. All patients' electronic data records were searched for information on demographics, investigations, treatments, and outcomes. In total, 70 patients were included in the analysis, 36 patients underwent a Heller's myotomy during their treatment pathway, and 28 of these received it as their primary treatment. 30 had pneumatic dilatation as their primary treatment, and 12 had botox as their primary treatment. 28 patients had Heller's as their primary treatment. The others were following either pneumatic dilatation alone or a combination of pneumatic dilatation and botox. When assessing the outcomes, only one patient, which accounts for 2.7%, required pneumatic dilatation following their Heller's myotomy, and this patient had a symptomatic improvement following a single dilatation 22 months post-operatively. No other patients required further treatment following their Heller's myotomy. The mean length of stay was 3.8 days for all Heller's. All cases were completed laparoscopically and all had a fundoplication to minimise post-operative reflux. Almost 20% of patients had an intraoperative mucosal tear. However, these were all recognised intraoperatively and sutured at the time of recognition, and there were no post-operative leaks. 30 patients had pneumatic dilatation as a primary treatment. In total, there were 48 dilatations in all patients. Most patients were discharged on the same day or the following day after their dilatation. Patients undergoing dilatation as an emergency, so for example during an acute admission with dysphagia or nutritional issues related to achalasia, had a longer mean length of stay. 6 patients required subsequent Heller's myotomy. 3 of these had undergone multiple pneumatic dilatations as part of their treatment, so only a small proportion of patients needed additional procedures after pneumatic dilatation. The median number of dilatations was 1, with patients undergoing between 1 and 3 dilatations in total. All had 30mm or 35mm balloons used, and in patients having multiple dilatations, there were approximately equal use of graded pneumatic dilatation versus the same balloon size being used on subsequent dilatations. There was 1 perforation, which accounts for 2% of procedures, and this was managed conservatively with total parenteral nutrition, and the patient had a symptomatic improvement following recovery. 12 patients had botox as their primary treatment. 25% of these were given by other sites prior to referral to our unit, potentially as a temporising measure for the patient's symptoms while they are awaiting further assessment. 1 patient has had botox while they wait for their Heller's myotomy, which has unfortunately been delayed due to the impacts of COVID-19 on elective surgery in the United Kingdom. There were no complications and there was some clinical benefit, which is consistent with the literature, although we know that the symptomatic benefit is short-lived. The median dose injected was 100 international units. Patients undergoing botox were older, with a median age of 78 years, compared to those undergoing alternative options as their primary treatment, having a median age of 53.5 years. Additionally, patients undergoing botox often had other significant comorbidities. 4 patients subsequently had pneumatic dilatation, one of whom later required a Heller's myotomy. This patient has had some improvement, but does remain symptomatic and therefore remains under close follow-up as a result. In summary, both laparoscopic Heller myotomy and pneumatic dilatation offer good symptomatic relief to patients. Although we have demonstrated both to be safe treatments, as consistent with the literature, the potential complications can be life-threatening, and it is important to be mindful of this. Botox can give short-term symptomatic relief, but is typically reserved for those too frail to undergo the more invasive treatments. An individualised approach with MDT input from surgeons and gastroenterologists with subspecialist interests is likely to ensure excellent outcomes given the low prevalence of disease. Some patients may experience disease progression, and it is therefore essential patients are closely monitored for any symptom development. More data is required to highlight factors that may predict disease progression. Thank you for your time. I'm happy to take any questions.